And yeah, after knowing whether if we have a stroke, knowing that type of stroke, because you said ischemic stroke is the most common, we have to know how to treat ischemic stroke. There, our goal is number one, to restore flow, either by, we have already treatment, meaning when you say treatment, you can reverse stroke. If the patient comes in on time, at the right place, at the right time, with the right person or team, we can treat stroke, we can treat an occluded vessel effectively, restore blood flow effectively, and can change the life of our stroke patient. Instead of having disability lifetime, they may be back to their normal functioning self. No? And then another goal is to limit injury. There are already interventions where we can protect the neurons, the ischemic neurons, or the dying neurons from making them more resistant to ischemia, so that they have a better chance of surviving. No? Okay, then we have to limit injury by addressing the complications of this. That is an ischemic stroke, not just neurologic complications. We want also to address medical complications resulting from the condition patient, meaning a patient who is paralyzed, who's in bed, they can have a lot of complications. No? Next goal would be to prevent stroke. Let's see. 24-year-old. Female, hypertensive, non-diabetic, non-smoker. Presents at the ER with acute onset of right facial weakness. Blood pressure is 140/80. Rhythm, heart rhythm is regular. Glucose is 80 milligrams per deciliter. Does she have a stroke? Stroke? Does she have a stroke? Yes? No? Yes? No? Wala na. Nahurot na itong time. Wala kayo pinumbra na bilin. Core na tanan. Decide. Stroke or no stroke? No? Stroke. Many said stroke. By what? Rational. By what reason would you consider stroke? Acute onset, diba? Sudden, the key is sudden onset of neurologic deficit. Acute onset of facial weakness, kaninang buntag, pag mata, okay pa, natubang sa mirror, facial weakness, until proven otherwise, that should be considered a stroke, until proven otherwise. I'm not saying that this is already a stroke, but you have to suspect it's a stroke because it's acute onset of neurologic deficit. Huh? Okay, that should be, the approach is think of a worst scenario first. You will not be faulted if you consider this a stroke, and that's the usual scenario. Patients will go to the emergency room because of this acute facial weakness. But on second or deeper analysis, this may not be a stroke. Do you agree? Look at the facial weakness. Now this is where you need your anatomy, neuroanatomy. This picture actually is neuroanatomy. I showed this before in your class. Okay, why is that stroke? But our first approach is consider this a stroke. Maybe on further examination, maybe this may be a stroke limit. Okay, we will find out why. She has the risk factor, isn't it? But only one risk factor. The more risk factors you have, the more chances you may have a stroke. Huh? So that's the objective. In trying to prevent stroke, we want to eliminate or address more risk factors. Her only risk factor is only hypertension. Her age is not yet a risk factor, is 24. Non-modifiable risk factor is 65 and above. The chances of getting a stroke is increasing already when you're 65 and above. With age, vessels will get somehow occluded or steeper. Okay. There. If it's just pure facial weakness, like in this patient, she has a Bell's palsy rather than a stroke. But that can still be a manifestation of stroke, a facial weakness, if you hit the brainstem. but usually it comes with other signs or symptoms, which is pure facial weakness. Bell's palsy, especially we have other findings of Bell's palsy, tenderness here. It's the whole half of the face is there. It's the whole half of the face that's paralyzed. Whereas in stroke, usually it's just this half of the face. 1/4 of the face is paralyzed. That's where you need to review your anatomy. Why is this stroke? And this one is Bell's palsy. The pathology is in the stylomastoid foramen, where the patient, the cranial nerve is pressed. Can you still remember? No, your anatomy is only first 2 years ago. Why is it peripheral facial palsy? Consider peripheral facial nerve palsy. Whereas the one with weakness to the half of the face, the lower half of the face, is a central type of palsy. Central meaning upper motor neuron is involved. This one is lower motor neuron. You have to review that. There, I'm already showing you the pathway that is involved here. What is involved with here, upper motor neuron here. The whole half of the face, what is affected is the peripheral nerve. So that's why it's not a stroke. Stroke involves neurons here in the brain. Okay. Okay. And for you to know the manifestations of stroke, last week was anatomy. When the anatomy, cerebral anatomy is discussed, very important. We have to review our cerebral circulation. What areas of the brain is supplied by the middle cerebral artery, anterior cerebral artery, posterior cerebral artery, vertebral, basilar arteries, choroidal. Okay. There. We have to review the homunculus. Middle cerebral artery, di ba yan itong mnemonic? This area, if you hold your brain like this is the area supplied with the middle cerebral artery. If you open the anterior part of your frontal lobe, this will be middle anterior cerebral artery. If you open the occipital, here, the interhemispheric tissue here, the occipital, that will be your posterior cerebral artery, meaning the mesial portion plus portion of the temporal lobe here. Posterior cerebral artery. There. And then you have the homunculus. When you have middle cerebral artery, territory infarction, meaning the middle cerebral artery is involved, included, this is affected. Motor strip is affected. You will have a type of weakness, diba? You will have weakness. Kasi motor strip on the ego. This is the territory under MCA. You would expect contralateral weakness. And the type of weakness is, the upper limb is weaker than the lower limb. I still remember lecturing this in first year. Whereas ACA, you also have weakness because it also supplies the mesial portion of your motor strip. And in the mesial portion of the motor strip, you have the homunculus for your leg. There, that is mouth, face, thumb, fingers, hands. In this area supplied with the middle cerebral artery. Whereas the hip, the legs is there. Into the medial portion, mesial portion of the frontal lobe, under the territory of the ACA. So the weakness is different. Weaker the leg than the arm if it's ACA. Now what if weakness siya 0/5 and 0/5 sa siya? What artery was involved? Weak 0/5, paralyzed good. What artery was involved? It's the MCA and the ACA territory. So which artery got included? the main stem artery, which is the internal carotid. It branches now to the MCA and to the ACA, so the internal carotid, even proximal and occlusion. See how the anatomy guides us in making a diagnosis. Okay. So you have somebody with plegia, upper and lower, think of that, maybe it's a large infarct. It involves MCA and ACA. And the vessel occluded is an internal carotid artery. So you have to review your cerebral circulation there. Middle cerebral artery, only that. But if it's more proximal internal carotid, which is the stem of your middle and your anterior cerebral arteries, now it's internal carotid. You don't have weakness, you have visual complaints, anopsia. What artery is involved? Posterior cerebral artery. Kasi it supplies occipital, the visual cortex. You may just have manifest with visual complaints, no weakness at all. Kasi it doesn't supply the motor strip. You have blank faces. When you have blank faces, what arteries are involved? Na all arteries poorly supply ng mga neurons, kaya nakalimot na. Okay. When you're asked and you're not able to answer, what arteries involved? Aphasia na siya. What type of aphasia is that? I ask you, you don't answer me anything. It's global aphasia. Now I ask you and you give me a wrong answer. What type of aphasia is that? What type? Wording is aphasia. Receptive. You don't understand that. You don't understand the question. That's why your answer is also correct. Ito ba? So which one is a bad prognosis? Global, receptive, or what's the other type of aphasia? Wernicke's and Broca's. Expressive aphasia. In the clinics, there are, the analogy is, when you're a clerk, it's global. You don't understand the question and you don't give us a good answer. When you're an intern, you understand the question but your answer is wrong. Broca's na lang. When you're a resident, maybe it's already better. Receptive na aphasia. So you have to, so these are deficits for you to remember. Okay, let's go. There, again, the territory is supplied by the middle, anterior, and posterior cerebral artery. So note down, kasi depending on which artery is involved, we can predict the areas of involvement. Huh? Okay. Now see how will we be able to get our patients on time if the lay they don't understand what stroke is. They don't know what the symptoms of stroke is. So we have to have a campaign, and that's what we're doing, public awareness campaign, to tell them that they have a stroke, and if they have a stroke, they have to present the emergency room as an emergency. Nah? Unlike cardiologists, they have good business. How does a cardiac patient manifest when they have a heart attack? Pain. If it's pain, it's embedded in the brain of lays that if it's pain, that's a heart attack. Chest pain is a heart attack, so they know it's an emergency. So they present to the emergency room. Whereas stroke, what is the manifestation? Weakness. What do the lay interpret that? Pamaol, pasmo, magpahilot sa, manawag o mahilot, wala na. Already late for the golden period of opportunity, or the window of opportunity. They call the hilot as numbness. Now they're not alarmed by numbness, but if it's pain, chest pain, they're alarmed. They know it's a heart attack. They know it can kill them. But when it's numbness, weakness, their interpretation is spasmo lang na siya. Okay. They just need to rest or call the hilot. So they lost time. When they lose time, they will lose brain, neurons. So this is our campaign. We ask them to identify stroke by identifying the most common manifestation of stroke. Meaning these are the more commonly affected areas of ischemic stroke. Motor system, sensory system, speech. Okay. So here, remember, be fast. Balance can be affected. Eyes can be affected, either blurry, double vision, arm weakness, in facial weakness, slurring of speech, and then the other is trouble or terrible headache. Now, if it's terrible headache, what is the type of stroke? Severe headache. Maybe it's not an infarct, at least we picked up na siya hemorrhagic stroke, subarachnoid hemorrhage, or a parenchymal hemorrhage, or a large infarct. So here, this is the campaign. When we go out to the community to educate about stroke, we tell them to remember, be fast, or fast. Time, T is time to bring the patient to the emergency room. Later, but nowadays we're campaigning that when they identify the signs, or when they recognize stroke, it's an acute stroke, they should bring the patient. It's time to bring the patient to a hospital that is an acute stroke-ready hospital that is capable of addressing or treating acute stroke. Not all hospitals can treat stroke. Do you know that? Where will you bring yourself if you have a stroke? Maria Reina? Polymedic? Premier Hospital in the city. Where? Where will you bring yourself? Or your mother? Maria Reina, kasi our training hospital. Ace, see you. Where will you bring? It's not any emergency room or any emergency hospital. JRB? Or St. Luke's? Now you will lose time flying, getting a ticket, flying. By the time you go to St. Luke's, you will lose your penumbra. Okay. Later you will know where to bring yourself for your case. So this is facial droop. Remember that. You ask the patient to make a smile and see if there is a weakness just on the lower half. That is a stroke. Arm drip, you may not see a very prominent weakness. To notice for subtle weakness, you ask the patient to put his arms forward like this in a supine, and you will see a pronator drip. Why? Why not a supinator drip? Why a pronator drip? If this limb is big, stronger a pronator than the supinator, so you will drift like that. Okay. And the best clue of a stroke is presence of risk factors. Now, if you have already elderly mother, diabetic si mama, hypertensive, smoker si father, that is already, you have to think of stroke because they have the risk factors already, whether modifiable or non-modifiable. And abrupt onset of symptoms, suddenness. That's a very important clue. Pag sudden, you're still sitting here and then suddenly you drop with a left-sided weakness, stroke na siya until proven otherwise. Two most common stroke meanings are hypoglycemia and seizure. They can manifest like suddenness, hypoglycemia. When the hypoglycemic episode, you can lose consciousness, you can slur, you can get confused with your hypoglycemia. Seizure, you can also have sudden onset of deficits. Actually, not deficit, but it can be activity, hyperactivity, like when you have tonic-clonic type of seizure. Okay, you can lose consciousness. In our case, that was a Bell's palsy case, the lady. Okay, but the attitude is to consider any sudden onset of neurologic deficit as stroke until proven otherwise, because you don't want to miss on a condition that is treatable and that can be more serious. Okay. And in the emergency room, we have this scoring system. We call it Rocher, recognition of stroke in the emergency room. So there, the elements are still numbness, weakness, slurring of speech, and then sudden onset. Seizure, which is ischemic, is scored negative. So you have a score of 1 or more, think of a stroke. So this is how we teach our nurse, our triagers to identify a stroke in the emergency room. Yeah? And we take a blood glucose kasi baka hypoglycemic. Okay. And the type of stroke, we can predict what the type of stroke is, but we cannot ascertain just based on clinical syndrome. Somebody who presents with rapid deterioration, maximal onset of deficit, maximal at onset. What is the type of stroke? We consider number 1, hemorrhage, or embolic stroke can be maximal at onset. While taking the breakfast, suddenly drops with a left-sided weakness or becomes aphasic, think of an embolic stroke. Think of hemorrhage. Okay, there is a pattern of maximal at onset. Think of an embolic stroke. The deficit is down, then it persists like that. Or a rapid deterioration in a matter of hours or minutes. And then lacunar atherothrombotic can be step-ladder progression. Upon waking up, the patient is complaining of weakness in the leg, or upper in the arm, and then during breakfast it becomes weaker. The limbs become weaker. Then that may be a step-ladder, a progressive weakness in a matter of hours or minutes. Think of atherothrombotic as a mechanism. Lacunar may be fluctuating. The lacunar type of stroke can be fluctuating, and also step-ladder. Okay. And these are the questions we want to ask when we presented when we suspect of a stroke. Time the patient last known well. That is very important information. When was the patient known to be well? The time patient was known to be well. Okay, that will be the onset. You will be able to tell the onset of the stroke. It's important because we said we have a narrow window of opportunity where we can intervene to lyse the clot. Beyond that window of opportunity, the medication or the intervention that we will do may not be effective anymore. Why? Because we lost the penumbra. With time, with every minute, we lose neurons. So even if you remove the clot, restore the blood flow beyond the golden hour, the window of opportunity, you will not be able to save any more neurons. And it may be even dangerous to intervene beyond the window of opportunity. So the time symptoms were first observed, and whether it's important it's not always easy to ascertain what time, because Filipinos, they don't look at the time. So how can you determine the time? You have to be creative. Filipinos they don't know the time, but they don't know. They don't tell. They don't look at the time, but you can determine time by what they're doing or what they're watching. What TV programs they're watching. Like what is the favorite show now in Kapuso? So sometimes we determine the time of their onset by what time what they're watching TV. You can establish the time there. So you have to be creative in asking for the time. So maybe it's in their cell phone when they call somebody for help. So that you can determine the time when they call. And the risk factors, the different risk factors, whether there's a fall, like we have one misdiagnosed case, treated for stroke, but we thought it was traumatic. He had dizziness, and then he fell, and he became quadriplegic. So he was misdiagnosed as having a stroke in the emergency room because sudden, but the history was more of traumatic injury to the spinal cord. He fell with the face on hitting the floor. Most of the injuries is in the face and here anteriorly, and maybe he extended his neck. That's why it caused a traumatic cord injury. Okay, and then other events involving the other vascular beds, like if you have MIs, heart attacks. Remember, what can happen in the coronary arteries can also happen in cerebral vessels. Atherosclerosis is not just a focal or a localized pathology. It involves many vascular beds. Meaning, when you had a heart attack, you're at risk for a stroke. When you have a stroke, atherosclerotic stroke, you're also at risk for coronary artery disease. Atherogenesis doesn't involve only cerebral vessels. It can involve coronary, renal, and even peripheral arteries. Okay. So a patient with a prior stroke also has a higher risk of getting another stroke than somebody who did not have a stroke. Or what is a TIA? Transient ischemic attack. Okay. And what medications the patient is currently taking. Remember, there are drugs being given to a patient to prevent an ischemic type of stroke. But that drug can also be a risk factor for developing the second type of stroke, which is a hemorrhage. Now, that's the difference, you say, between a cardiologist and a neurologist. Cardiologists, they only have to worry about myocardial infarction. Have you heard of myocardial hemorrhage? Have you heard? Somebody was diagnosed with myocardial hemorrhage. Heart attack, myocardial hemorrhage. No, you haven't heard, unless you maybe stop that patient, and then he has a hemorrhage into the heart. They don't hemorrhage. What gets occluded are large vessels, but the small vessels, they don't rupture in the myocardium. Here, we have to worry about rupture, hemorrhagic stroke. And the medicines that we give for trying to prevent ischemic stroke can be a risk factor to a hemorrhage. What are these? What do we give? We give blood thinners, aspirin, antiplatelets. We give anticoagulants, so they can put the patient at risk to a hemorrhagic type of stroke. Yeah? Okay. So I think that makes our job more difficult than cardiologists. They only have to worry about infarcts. So they're very brave in giving antiplatelets, anticoagulants, but we are very careful in choosing our patient to give, whom to give, who to prescribe, antiplatelets or anticoagulants, because we're worried about hemorrhagic stroke. Okay. So here, to be able to effectively handle stroke patients, we have the many D's to remember. It's a do or die. Here we have to detect whether they have a stroke, and detect on time, early recognition. Otherwise, we will lose that window of opportunity. Remember, stroke happens most of the time in the community. Now, how do they get to the hospital? By ambulance? by motorellas in our hospital. They come in not by ambulance, although now we have educated our 911 ambulance in the city to identify stroke patients and to bring them to the acute stroke ready hospital. Not to any other hospital, but to an acute stroke ready hospital. So remember, in every step, getting the patient from the site where they develop the stroke, say at home, to bring the patient to the emergency room, that takes time. Okay? And then when the patient arrives in the emergency room, it takes time for the patient to be examined, to be evaluated for stroke. It takes time for the patient to be worked up, to do the imaging, so you lose time during the process. It takes time to call the neurologist or to the stroke team. If you bring them to the wrong hospital, the longer the delay will be. Okay. So the business of taking care of stroke is not just in the emergency room. It starts even in pre-hospital, public awareness, organizing the emergency room, and then admitting the patient in the right unit. Where do you think is the right unit to take care of the stroke? Is it the ward, private room, ICU? Have you heard of stroke unit? It's a stroke unit. It's a unit, geographic unit, where we place our stroke patients, solely our stroke patients, where the staff are trained to handle stroke night and day. So those are the patients that they handle, only stroke patients. So they are trained, they can identify defibrillation, they can identify complications, so that makes it more efficient. Just putting them, stroke patients in a stroke unit, improves the outcome than when you put the patient in the regular ward, in the private room, or in the ICU, where staff are not trained to handle them. And then, rehabilitation. Not all will be able to get back to their normal function, so we maximize the recovery through early rehabilitation. Okay, so look at the phases there, where we can have delays in managing stroke. Pre-hospital pa lang, lapas mo. Ang gitawag is the hilo, not the ambulance, so you already lose time there. And then, patient evaluation in the ER, imaging, you know how busy the ER, the CT scan is? We're not handling only stroke patients in the emergency room. The radio unit will not be doing CT scans of the brain only. They will be doing a lot of this. So there's priority in getting into the CT scan or the MRI. So we have to have an organized process to give priorities to our stroke patients, ischemic stroke patients, to be able to treat them on time. Okay. Look at the proven interventions that can change the outcome of stroke patients. There are 5 as of now, and I think there's another one. Management of patients within an acute stroke patient. That's what I'm saying. Just putting them, admitting them in an acute stroke unit where staff are trained to handle just stroke patients improves the outcome. Compared that when you're being taken care of in regular ward. Giving of aspirin, antiplatelet within 48 hours of an ischemic stroke improves the outcome. Hemicraniectomy, that is for a large infarct, posing as a mass with an increased intracranial pressure, with the potential to cause herniation and death, addressing that by removing a big chunk of your skull, so for swelling to go out rather than press on the brainstem, improves survival. Proven if you do that. So the stroke unit and the team are capable of doing that, of anticipating that complication. Yeah? And another, number 4, is use of thrombolysis intravenously within 4.5 hours of stroke onset. We have the drug, you cannot buy it in Mercury. It has to be in your hospital, and your staff should be competent, should know how to give it. You cannot buy it in Mercury, it's not available. It's bought directly from the company, and it's only available in just maybe now just 2 hospitals in Neuro. And it must be given within 4.5 hours from stroke onset. That's why it's very important to know the onset of stroke, establishing the onset of stroke, because if you give it beyond 4.5 hours, it will not be effective and it will be dangerous. You end up with hemorrhagic complications of stroke. And the other is mechanical thrombectomy, removing the clot mechanically. So putting a microcatheter into the area where you have your clot and then pulling it out with a microcatheter, mechanical thrombectomy. Okay. So what can we offer? We can offer 1, 2, 3, 4, and we're supposedly capable already of doing mechanical thrombectomy, but we just don't have that microcatheter, that gadget to pull out the clot. It's expensive. I think it's still about $500,000. But we already have the infrastructure that where we can do it, the cath lab. We have 3 hospitals with a cath lab ready, and we have already 1 interventionist who can do it. But only we don't have the gadget to remove the clot. So we can do 1, 2, 3, and 4, admitting in the stroke unit, hemicraniectomy, giving the medications, and then thrombolysis here. So an acute stroke ready hospital is not any hospital. I ask you about where you will bring yourself. It's in the one which has extensive experience in treating acute ischemic stroke with IV thrombolytic agent is NMMC, a government hospital. There's just one private hospital that has started giving the medication. Maybe they only have 2 cases per month. But the Northern NMC, which is Northern Mindanao Medical Centrio, it's just beside Centrio, that makes it a good hospital. Okay, has been giving it since before pandemic, even before pandemic. Yeah? So it should have the capability of doing CT scan, diagnosing. It should have a acute stroke team, and stroke team, a brain attack team, who can respond to the emergency. Yeah? Stroke is an emergency, okay. And should be able to give the drug when the patient is eligible. So look at this. These are the processes or the steps the patient has to undergo before treating, before receiving the treatment, the IV thrombolytic agent. We have a lot of So we have a lot of checklists, items in the checklist. There's a lot of contraindications, okay. And then we need to work within a very limited time. That's why there's a DTN, door to needle time. So when we receive a patient in the emergency room, we want to give the drug, if the patient is eligible, within 60 minutes from arrival. So meaning we have to process everything from diagnosis, imaging, to decision making to give the drug. Within 60 minutes. Remember, the patient already lost time before coming to the emergency room. And so you only have 4.5 hours for that drug to work on a fresh clot in the cerebral artery. Okay, this is how we audit our service, stroke service. So we have timetables, like if you have an acute stroke ready hospital with a team, you want the patient to be seen by the doctor in 10 minutes. See, in a busy hospital or a busy emergency room, it's not easy to do that because we have other patients who are not stroke patients. No? And identifying that there's an acute stroke patient there among the many other patients is not easy. So we have to have that team to be able to sort out the patients in the emergency room. Then there, for example, door to CT scan completed within 25 minutes. We want the patient scanned. The procedure takes less than a minute, but bringing the patient to the CT scan room is it will take more time. Did you know what's the fastest world record from onset of stroke to doing the CT scan? Wild guess. 5 minutes? How can you do that 5 minutes? Meaning from the onset of stroke, from the patient has a stroke in that home, and how can you get a CT scan in 5 minutes? Huh? 20 minutes? Or another, from the time the scan, from the onset of stroke to the time the drug was given. Meaning he has completed all the processes, imaging, CT scan, decision making. What do you think? 2 hours is the shortest. We were able to give it in NMMC in less than 30 minutes from onset of stroke. Because the patient had a stroke in Gaisano. That's true. In Gaisano, he was brought to the emergency room. Less than 30 minutes, we were able to give from onset. World record, what do you think? I'm not sure. I think it's less than 15 minutes. How did they do? Did you know how they do it? Patient had a stroke at home. They did the scan at home. They give the drug at home. They have a mobile ambulance with a CT scan. It was in Germany, I think in Germany. We don't have that. So you're just lucky if you have a stroke in the hospital and we're able to facilitate the scan very fast and decide. Huh? So the shorter the time, the better you will have a better chance of getting a good outcome. Okay. So this is already a standard of care. Did you know when this was first given in Neuro or in the Philippines? This one. All patients with acute ischemic stroke who can be treated within 4.5 hours after symptom onset should be evaluated and treated if they are eligible with tissue plasminogen activator, the drug that I'm talking about. It was approved in international. It was first approved in 1996, I think. 96 or 97. As a drug and a cure for stroke, meaning it can lyse the clot, reverse things. 1996, that was the time I just finished my residency. So it was given already in other countries, but in the Philippines, we're always like 10 to 20 years late. No? In Cagayan de Oro, do you know when it was given? So 1997, approved na as a standard, as a care, as a cure, as a treatment for stroke. But we were able to give it maybe in the 20. The first patient was a doctor. 1997, imagine, so we were able to give it in 20 something, before maybe 2017 something. So we're late. But now it's a standard of care. Meaning, even if you're in third world countries, it should be offered on top. But if you don't have the infrastructure, you don't have the team, you don't have the hospital, you're not able to do it. It's not just a simple a simple way of just injecting it. No, you have to have screening, and timing is important. Huh? But that's good thing we're not able to give it here, and only in Northern Medical Center. Okay, this is a drug, and it's very expensive. It's one vial is about 50,000. Yeah. Depends on your weight. If you weigh 70 kilograms, you will use 2 vials. So it's already 100,000. Yeah. But it's life changing. It can change your life. Imagine you're not given this drug, you end up disabled for life. If you're lucky and you improve with this drug, you're safe from being disabled for life. So it's more than 100,000. Not being disabled for life, a lifetime, you can save more than 100,000. Okay. So there's again concept of time is brain, time is in brain with thrombolysis. Because of this, the drug is still effective, is beneficial in the first 4.5 hours there. The green line, that's the line of benefit there. It drops with time. By 4.5 hours, you will have already increasing harm. And the harm there is converting that infarct into hemorrhagic transformation. So the key, the take-home message there is to give it the earliest possible time. We do not wait for 4.5 hours from the onset of stroke. The earlier, the better. The better, the more neurons we're able to save. Okay. So with stroke, time loss is brain loss because of this curve. Impact of thrombolysis. Okay. Here. So when we do a scan, we know it's still early if we don't see anything in the scan. Meaning the brain, we expect it to be normal. You have a stroke at 6 o'clock this evening. We do a scan now at 7 o'clock, 1 hour after the onset of stroke. We don't see anything yet in your scan. If it's an infarct, basically your brain is still normal, or we see early changes. Not the infarct, but edema maybe. Early edema, effacement of the gyrus, edema of the gyrus, effacement of the suicide, like this one. But if we see this is already a full-blown infarct. Your 60,000, 50,000, or 100,000 is useless. We cannot give any more of the drug. That is already full. That is already an infarcted brain. We will not be able to save that anymore. We want to see when we get an early stroke, this one, just some edema, blurring, compression of the suicide, blurring, compression of the suicide, but not this one. You can still be eligible for thrombolytic therapy, restoring blood flow by lysing the clot. Okay. So see how this is being done in our local setting. This is a video, not a local one, but you can picture that this is happening in our.
This video is produced by the South Australian Stroke Clinical Network as a training tool for nurses and doctors. It explains the code stroke scenario which we use in this stage to ensure rapid assessment of patients to enable administration of thrombolysis wherever possible. Okay, so the bolus is at 11:40 and we'll keep a close eye on it. The community need to recognise a stroke and know what to do. Spread the word of FAST. F for face asymmetry of smile, A for arm weakness, S for speech disturbance, and T for telephone 000 in Australia, and note the time. Once the ambulance service has been called, the code stroke process begins. And the time of onset was? Okay, see you in ED. Thanks for the call.
Roger, see you on.
Following the pre-notification, the stroke nurse then activates the hospital code stroke team. The stroke team meets the patient on arrival in the emergency department. ISBAR is a tool used to provide effective and accurate communication. I for introduction, in this case the 49-year-old Mr. Bob Major. S for situation, he was at work with a sudden onset of left face, arm, leg weakness and slurred speech. Time of onset was 11 o'clock. The B for background, he lives independently at home with a past medical history of atrial fibrillation. A is for assessment, the Rosier score, recognition of stroke in the emergency room. He scored 4 with a face, arm, leg, weakness and slurred speech. R is for recommendations, an acute assessment by the stroke team for suitability for thrombolysis. In a code stroke scenario, all members of the emergency department and stroke team have predefined roles, so it's a very rapid assessment of the patient. We do things like heart tracing, taking bloods, putting in the gelco, telling the patient what's going to happen, doing a neurological assessment, and then transferring them to radiology within about 15 minutes. The National Institute for Health Stroke Severity Scale is known as the NIS. It enables doctors and nurses all over the world to make a standardised assessment of the severity of stroke. Well, we need to do a neurological examination on you. Tell me how old you are.
49.
What month is it now?
It's March.
Do this for me. Close your eyes. Now open them. With your hand, make a fist and open it out. See my pen here? Don't take your eyes off my pen. Follow my pen all the way. Point to the finger that wiggles. Point to the finger that wiggles. Okay, so it's got some left visual neglect. Give me a great big smile. Show me all your teeth. Screw up your eyes tight and raise up your eyebrows so it's weak on that left side. Now, I need to know whether you can feel this as sharp.
Yes.
Can you feel this?
Yes.
It's not sharp. What about here?
Yeah.
And here?
Just.
Okay, sharper on the right or the left?
Much sharper.
What about here?
No,
So you can feel it, but it's not as sharp. So we've got some left sensory loss. Lift up your right arm, keep it up strong for 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Lovely. Lift this one up for me. Come on, lift it up. What can you do? Anything at all? Pretty weak, isn't it? Okay. So I'm going to give him a 3 for his arm. Lift up your right leg. Keep it up for 5. 1, 2, 3, 4, 5. Rest down. Lift up your left one. Come on, lift it up. What have we got here? Anything? Okay, still very weak. With this finger, touch my finger, touch your nose. Back to my finger, back to your nose, back to my finger, back to your nose. Can you try with your left hand? Okay, there's no ataxia there. Now, just rattle these words off for me, please.
Hip, stone, 15, catastrophe, impossibility.
So we need to rush down to the CT scan. I'll run them to say we're on our way. Hi Andrew, this is Bob Major for his code stroke imaging.
Hi Bob, have you ever had a CT before?
I don't think so.
I'm going to take you in so we can do it, please, yeah?
As part of the code stroke imaging protocol, all or some of the imaging is performed. Everyone gets a plain CT scan to determine the type of stroke and to rule out a bleed. CT angiogram is performed to look at the intra and extracranial vessels. A perfusion scan may also be performed, which highlights already infarcted brain or whether there's brain at threat of infarction. This is the penumbra, and that's the brain you're trying to save. In preparation for thrombolysis, the patient must be informed of the risks. 1, the drug will do nothing. 2, it may make you better or totally better. 3, and this is important, it could make you worse. It could make you bleed from anywhere in your body, especially your brain, which could be serious and even life-threatening. Other problems include allergic reaction and local bruising. Reassure the patient they will be monitored very carefully for signs of deterioration over the next 24 hours. There are absolute contraindications to thrombolysis, which include if there's no clear time of onset, an uncontrolled blood pressure of 185 over 110, serious bleeding or clotting disorders, an INR of greater than 1.5, or seizure at onset without vessel occlusion. Relative contraindications include recent heart attacks, strokes, head injuries, a very severe stroke with a NIS of greater than 22, operations or biopsies. The stroke doctor will discuss the patient with the consultant. He will give him a clear time of onset, the clinical findings, the medical history, the blood test results, and the results of the CT scan. The consultant will review the images and the patient and decide whether thrombolysis is indicated. And the drug will only be offered if the stroke consultant thinks it's the best treatment for the patient.
Bob, I want you to sign this consent form for thrombolysis.
Bob, how much do you weigh?
89.
89 kilos. The total dose is 18.1. 10% bolus is 8. 60 ml infusion is 72.1. And we're using 2 50 milligram vials.
Okay, so our infusion will be 72.1.
That's correct.
Actylise is given 0.9 milligrams per kilogram. The maximum dose is 90 milligrams. It will come in a 50 milligram vial and a 10 milligram vial. The patient will have cardiac monitoring in situ and be constantly checked to observe for bleeding, headache, changes in clinical signs, signs of allergic reaction, angioedema, and anaphylaxis is rare but possible.
All right, Bob, we're going to keep a close eye on you.
By completing standardised neurological and frequent vital signs observations, early detection of deterioration will be made. The modified NIS includes questions on level of consciousness, visual fields, gaze, arm and leg movement, sensation, language, and whether there's neglect, with a possible score out of 32. If the score increases by 4 or more, the patient is deteriorating and will need urgent medical review and possible rescan of the brain to rule out a bleed. You'll be pleased to know that our patient, Bob Major, made a good recovery with his thrombolysis and was discharged to rehabilitation on day 3.
Discharge only 2 days in the hospital. I remember when I was a clerk back in 1989, 90, clerk, our stroke patients were one of those patients who stayed long in the hospital, maybe for a month, 2 weeks or more, because we cannot offer anything. They end up disabled, bedridden, with complications, and they stay for 2 weeks or maybe a month in the ICU. Yeah? But nowadays we're able to discharge patients 3 days, 5 days from the stroke unit. Okay. Because of the expertise of our brain attack team, of our stroke team, and we're able to treat the patient, try to reverse the occlusion, restore perfusion, and improve survivals of the neurons. Okay, so this is one of the success stories of IV thrombolysis. So where will you bring yourself? Your family. And always remember Centrio, Northern Mindanao Medical Centrio. Yeah, but you don't expect to see this video, these things happening with only one nurse, one resident, or one doctor, and one patient in the emergency room. You will be in a very crowded ER. But your chances of getting good outcomes, if you happen to get an acute stroke or an ischemic stroke and you're eligible for the drug, is still less in NMMC. Yeah? If you go to Polymedic, they will transfer you to NMMC because they cannot offer this medication. They don't have a stroke team there. And in the transport, you will lose neurons. You will lose time. So rather than going to a private hospital, go to NMC. The only private hospital that was able to give the drug and is available, I think they already ordered for a vial for 2, is ACE. I just heard of it recently. Okay. But we have a team. Despite our crowded ER and our crowded stroke unit. And we are the only hospital with an acute stroke unit, NMC. 18 beds. 18 beds acute stroke unit. Okay. So I'm promoting the government hospital. If you're a politician, congressman, where do you go? Where do they go? They don't go to public hospitals, but they go to private hospitals. Our president, where was he admitted? Recently. I'm not aware of that news. He got admitted in a private hospital. If I will be a senator, I will propose a bill that all politicians should get admitted in a public hospital, not in a private hospital. Yes. So that is how to improve our government, Okay. But I still have a bias for NMC in terms of stroke care. Okay. So we want you to be MRS 0. No symptoms at all. But that's not the usual case for our stroke patients. You lose neurons, you lose function. About 1/3 severe, 1/3 somehow improved, 1/3 baseline stroke. Okay. But we want to increase the chance of our stroke patients to have more MRS, modified Rankin scale of 0 after they're treated well by our team and in our stroke unit. Okay? So here we have to educate, inform our public the way that stroke should be treated as an emergency, just like a heart attack. Okay. It's a long way to go to educate. We also have to educate even our health professionals to handle stroke as an emergency. And we can do that effectively if we work as a team, not as an individual. That's why I'm telling you, 1997 I came back, I wasn't able to give the job until I developed a team of co-workers. We have to work as a team. Assistant is to identify and treat, and we'll do all those imaging by yourself. Anything else? Okay, so see that difference? We know, but if we don't do, it's useless. So we know already, we know how to diagnose stroke, we know what works with stroke. But putting in the process is now our hurdle. Imagine 1997 and we're able to do it only these days. Do you know what the standard of care for stroke already nowadays? There's more effective way of restoring blood flow. It's now mechanical thrombectomy. Pulling it out with a gadget. Intravascular. That is the standard of care. It has been a standard of care in Europe since the pre-pandemic. But as I said, as a country, poor country, we're always 10, 20 years behind. So how will we be able to give that standard of care? So we have to put in cath labs. You know what a cath lab is? You have to invest on the equipment, the C-arm. You have to train personnel to be able to do it. Now, Europe, US was able to put it in place even before pandemic. Now we're just beginning. We're still beginning. So these are the challenges for us in a poor country. Okay. Questions? Can we change stroke now? At least identify and know where to refer or to bring your patient. Able to, yeah? Are you part of the solution or still a part of the problem? For the burden. Remember, 1 in 4 If not, I think we're late already. Can go?